though we're a couple minutes late, we want to make sure we don't get too far off. So, welcome. I know we've got a lot of information to present to you all today, and I think hopefully maybe you've been able to look at a little bit of it before now. But we've got some good presentations, and it looks like Sam is first.
Yep.
Sam, how are you?
I'm good. How are you doing?
Good to have you here again.
Thanks for having me back. All right, let's make sure we got this going. You just want me to jump right in?
Yes, sir.
All right.
Water.
So, as you may recall, we covered some of this at the last meeting. So we kind of closed 2 weeks ago with a preview of kind of what the process was, what we wanted to cover in terms of ambulatory network planning. And this is really part of our work with the coming team of the overall long-term facility assessment. So one of the gaps, I think, when we started this process was what would that ambulatory deployment network look like? And the focus was really on leveraging that model that you have in place, which is generally or primarily a primary care model. And we're going to go over that model a little bit. But replicating that model, getting the right footprint overall in your network, that makes the most sense. So today we're really going to then hit into the recommendations. So last time we kind of covered the markets, took a look at that, took a look at your current footprint. So now we're really going to look at what does that future footprint look like? Where should you be developing new clinics? What is the timing for all of that? Sort of how does that fit into the big picture? So as part of that, we're going to incorporate, update, and discuss those HMA primary care recommendations. So as you remember that 98 number from HMA at the last meeting that they presented, this is really utilizing that number as a sort of baseline. You're going to see how we tweak that a little bit to come up with recommendations, but we really started with that as the starting point in the baseline. The next part then is this evaluation criteria. So what we wanted to do was really understand priorities in terms of your market. Where are these health centers based on population, your type of target population? Remember that less than 250% of the federal poverty level, growth, access, all those issues. So you'll see the methodology that we use to actually come up with a quantifiable score for every zip code in your market, all 66 zip codes. And we use that to prioritize them. And then finally, how do you phase that over time? So this model that we discussed, this is really what you have in place today, and I think it's a good model. 6 to 10 primary cares is a good group size. You don't want too much less than that. You've got critical mass there to support. Some of your sites are at capacity. Some of them have a little bit of room. You want a mix of MD and advanced practitioners. I think today you're probably a little bit heavily weighted on the MD side. I think going forward you can get a little bit more of a mix there. Some of the sites, as we think about growing these over time, in some of the markets, now that we're really kind of looking on the outer part of the community a little bit, you might start out with 4 or 6 PCPs and grow up to that 10 and 8 or 10 base over time. You want to have, in some of them you have pediatrics, women's services, and embedded behavioral health, and I'll talk about that in a minute. Diagnostic imaging, which generally means X-ray, ultrasound and mammography, or bone DEXA in some of it, especially the sites that have women's services. Pharmacy and lab draw are those sort of typical ancillary support services that you have in these sites. Dedicated urgent care sites are not planned, and this is something we thought about in this process. We talked with folks at JPS and we looked at your market. I think as we looked at this, as we looked at really what your community needs, we didn't think it made sense to develop what we would call pure urgent care models. What we think makes sense is essentially what you have in place at some of your clinics today, which is really expanded hours and allowing walk-ins with no appointments at these clinics. I think that's a critical function to have. So we kind of call that a hybrid model. But you can flex that with the staff that you already have. You can actually use dedicated advanced practitioners for some of those urgent care services. So we did not look at any dedicated ones. Frankly, I think if you were to consider any in your market, it might be closer to the hospital campus just to relieve some of the pressure off the ED and the urgent care. Eventually you're going to get, the facility plan is to merge those services there. So that hybrid model is what we're talking about there. I think one thing is clear is that there isn't even where, in those clinics today where you have those services, there's not a great awareness of the availability of that. So I think one thing that the system could certainly benefit from is greater marketing of those services, greater signage of that, awareness of that. It could be a marketing campaign. It could just be signs outside that say walk-ins welcome or immediate care, or advertise the hours of operation, which are extended on the weeknights and then on the weekends as well. There are other select community health services as needed at these. For example, some of your enrollment services, dental services, etc. Typically the range that we're talking about for these is about 20,000 to 35,000 square feet. And most of yours today, I think with the exception of the Southeast Tarrant one, is bigger. There's another one that's bigger as well. But generally, yeah, there it is at 56,000. And that one has additional specialists. So typically that's the range. We are going to look at specialty stuff, but that's really in the next phase of this. So in terms of behavioral health then, the focus of this is really, again, on medical services. So we feel like that was covered pretty well in the HMA report. As you may recall, they talked a lot about integration with the community, utilizing some of those community services, developing substance abuse services. For this model then, what we're really looking at is embedding behavioral health in the medical home sites as needed. Now you already have that in place at some of these. You can see the 6 or so where you have that today, or 5. So I think that model, and you're really seeing that a lot more in primary care centers or clinics, so I think that model is really what makes sense for you. That way you don't have to invest in additional bricks and mortar. You do have that one site already in central Arlington, and I think that's fine. The other thing to keep in mind is, whenever you get to that final recommendation of a behavioral health hospital, one thing that was in there was a pretty comprehensive central assessment center. So that will also treat a lot of outpatients well, and I think will really help the services there. So I think in combination, all of that looks together. But as part of this, works together, but as part of this plan, we are not recommending necessarily dedicated behavioral health sites. And one of the keys to making that work at these sites is to have separate entrances, separate wait areas for those patients, so you don't necessarily mix them in with the population. And these are lower acuity behavioral health patients. The real problem behavioral health patients aren't likely going to be at their clinics. You want to get them in the central center, or the one in central Arlington. Finally, another way to tackle this issue is through telehealth services. So I think there's an evolving telehealth strategy at JPS, and this can be one of the areas that can be utilized to address that as well.
Excuse me.
Yep.
Was your recommendation to separate on the behavioral health where our prisoners go? Would that be a separate facility for the prisoners?
Yeah, I mean, that's part of the campus solution, so is really outside of the scope of that. And I know that we're looking at that, but I don't want to necessarily comment on that until we sort of have a full picture on that. But that is definitely an issue that is being addressed with the long-term main campus solution for that prisoner population. And you can actually use telehealth for some. We actually just visited a group in South Dakota called Avera, who actually works with their prison population through telehealth, and they've actually reduced the amount that the prisoners have to go to the hospital by 50%, so which is pretty impressive. So there are programs out there that you can use to address that as well.
I was having a conversation with Dr. Eugene Giovannini, the Chancellor of Tarrant County College, and he was wondering if we would consider opportunities for interning his Tarrant County College graduates in the medical tech areas at the clinics and the ambulatory care and so forth. And I told him I did not know if we are doing that right now or if we even entertain that. But if that is something that we want to consider, then that may have an effect on the ambulatory care network.
Yeah. Yeah, it could potentially reduce some of that.
Behavioral health, you consider drug issues under that category, or? Typically
that is lumped together, substance abuse. And I know you don't have a lot of those services now necessarily at the campus.
I think that implemented clinics would be better because it's not an hour-to-hour issue with that type of problem. It's a 7-day week, 24-hour issue.
Yep.
You know? And I think the clinic could do a lot to help people with those kind of issues.
I agree with that, and frankly, that can be part of that embedded care at these sites. I would recommend referring, the HMA report does get into pretty good detail around that patient population and solutions for that. But I agree with you that stuff is a community-based service. It often requires, you know, daily check-ins and updates to manage that.
It could keep a lot of people out of the hospital.
Yes, exactly. If it keeps people from having to come to the ED here, then that's certainly a win-win. You know, and right now, obviously, those patients are going up to the psychiatric ED, but those patients certainly can be very disruptive in the ED, so anything you can do to sort of alleviate that coming into your hospital is a win, certainly.
Can you explain a little bit about your recommendation for the square footage?
Yeah, that's not so much a recommendation as just the typical size you see for the host of services that we talk about. So if you go back to that, so if you look at this sort of complement of services for these primary care sites, and I would say that yours are a little bit more robust than a lot of health systems, because you do those, what I would call sort of extra community services, medical care, enrollment, pharmacy, so you do have a lot of patients coming in for that. So that does expand the square footage need and expand the need for wait space a little bit. But that's, so in some hospitals you might see a little bit of a smaller range, maybe in the 15 to 20,000 square foot range. But given, I think, the robust services with ancillary diagnostics, so if you sort of program that out, and I've looked at typical, we have what we would call prototype modules that look at, you know, this contingent of physicians and advanced practitioners with these services, and that's essentially what it comes out to in terms of square footage range. So it's not like, as if we're recommending that, it's really just a function of what's in the building.
Okay, I see, okay. So it depends on the bundling of the services.
Yes. Okay. And I mean, it certainly comes into play. I mean, once you know exactly what that bundle of services is and how many providers are going to be, the other thing that's important to note is you really, especially with the growth, as you develop new sites, you really want to think through the expansion possibilities at any given site. So it would behoove you to select sites that have expansion capabilities going forward. You know, even if it's just 5,000 or 10,000 square feet, that can make a big difference in terms of sustaining that site in the long term.
Okay.
All of our sites have diagnostic imaging, is that right?
At some level, I know the vast majority. I don't know if every single one does, but clearly the vast majority. Almost all of them have X-ray. Only a few of them, I'd say a handful of them, have sort of ultrasound, mammography, et cetera.
And then they all have pharmacies too?
Yes, they all have pharmacies.
Yeah. So when you start adding all that in, that's really not a bad size. What his range is there in the 20 to 35.
Yeah.
Because you figure, you know, 1,200 to 1,500 for primary care provider, and you started at 6 if it was brand new, plus all those services.
And when you go out and get sites, right, it's going to probably be a mix of developing your own sites. You'll see later on when we talk about one of the areas that we're looking at, you own some land there. So that one you can really develop and build a site from scratch. Other areas you're going to be either moving into county-owned space or leasing space from somebody else, and you're going to be essentially confined by the footprint there. So in some of those situations, if you have a little bit of extra square footage, you know, you might be able to accommodate certain things, or that might not be a big deal, but you certainly want to keep in mind what that range is that you're looking for.
Hi, and I apologize, I came in late, so maybe this question has already been asked. Embedded behavioral care were needed based on what versus an integrated model of behavioral and primary care?
Yeah, I would say, when we say as needed, I mean, it's mostly to say we're not plotting that out today. I think it really depends on a couple of things. You know, what is your ability to get staff? To develop staff for that, that's always a challenge. What is the capacity of the behavioral health services at existing sites? So, for example, if you have capacity, so you saw that list, was that on the previous page? No. Here. of your 5 sites that have behavioral health. You know, we have not analyzed the volume of behavioral health at those sites. That would be something you would want to do first to assess whether additional is needed. So if all 5 of those are basically have long wait times and at full capacity, then I think clearly you want to start to develop those. If not, then you know you might have more of a slower growth profile. The other thing is the assessment center. You know, to some extent, I mean, you know, the timing of that could still be a little ways out, but I think that will help relieve capacity as well. So they're all sort of different factors involved in that, as well as drive time. So I don't think it necessarily has to be at every site, and that's sort of why we say it's needed. Primary care target. So again, and we looked at this number last time, but I want to sort of show you how our thinking has evolved in this. So the challenge is looking at the numbers. You may recall, so this is HMA's table, by the way, and this was sort of, if you just maintain your coverage level today, you know, in 20 years, you would need an additional 50 or so primary care physicians. If you got to more of a target number, and they use that number of 50%, you know, you could see that that's pretty strong exponential growth there. Now, probably that's, to be honest, not a realistic number to add almost 200 physicians in that time frame. You know, that's basically, what, 10 a year. So that's probably a little bit on the aggressive side. As we thought about this, but we think that, you know, maintaining the minimum isn't necessarily the way to go either. So we tried to strike the right balance of what's sort of a reasonable growth pile. If you go by that model of 6 to 10 docs, and if you look at where you need sites, you know, do those two things tie together? The other thing we talked about, which is an important concept I want to talk about a little bit, which is what we call balanced capacity. So we looked at essentially the number of beds that you have to serve your population right now is about 34%. So we use that as a target because I think it's a little bit more realistic target, at least getting those in balance a little bit. So right now, when you have more acute care than you have primary care, you know, you're sort of pushing more care to that mode. If you can sort of balance that and have the same sort of level of primary care meeting your population that you do in acute care, then you're more in balance in that. So it just allows it to be a more efficient system. It keeps all of that in balance. As a system, you can say you're essentially treating at the acute care level and at the primary care level the same amount of the population. So we thought that was kind of a good number target. It also fit in pretty well. So if you look at that, and we use just sort of 30% as a barometer there of getting it at least up to that to be close to that balance. You know, that would be a target of 150 FTE in the next 10 years, which if you put these 4 sites together, you know, around 10 each, then you start to hit that target. And I would say that also includes all those 40 don't have to go at the new sites. You could put some at existing sites as well. But I think that's probably about a reasonable target and kind of fits with the time frame. You'll see when we look at 10 plus years, you know, there are going to be additional sites you're going to need. And to the extent that you're successful in terms of recruiting and still have capacity issues, you may want to accelerate that curve, but that's essentially how we plan this out.
I just
Yep.
want to ask, just so I'm clear in my mind, so do we put behavioral in each of these new sites?
Not necessarily. I think you want to consider it in each of the new sites. Again, I think you want to look at your volumes, look at where you are, look at how much room is in the new sites, look at how the model's working at the existing sites, and if it makes sense, then to go ahead and do that. So I would say more likely than not, but you know, it's something you want to examine at each site.
Yeah, I would think it would be more likely than not.
Yeah.
If you don't know, do you really? Yeah.
Yeah.
I mean, just based on the explosion of that particular.
Based on what you need, you know, and if your system can accommodate that and you find enough providers that can go to those locations, then I would say yes, that would be the likely scenario.
That would be one of your biggest hurdles right there.
Yeah, exactly, it's hard to find.
So you may want to do it, but there just aren't a lot of them coming out.
Yeah, or they may not want to go to the location that's there, so.
And,
you know.
and is there a stream of behavioral doctors that we can tap into?
Sure. It's just that.
But I think the commissioner's admonition about, you know, maybe we can use people from, I'm just thinking how we can
Sure.
I must tell you, I have what I saw at John Peter Smith fixated in my mind, and
Yeah.
how can we help that?
Yes.
How can we, if we can spread it out, the disparity, spread it out a little bit to give him some help.
Yeah.
That's
I think spreading it out and also getting on the front end of it.
front end.
Because, you've got a lot of needs that get identified by the primary care doctor, but the primary care doctors, they don't know where to send some of these folks, because a lot of these folks are already in full practices.
Yeah.
So if we could possibly design a model where they're able to effectively move this patient that they've been seeing as a primary doctor right down the hall before they, I hate to say the word escape, because that has different connotations, but you know what I mean. You want to just take them over to the next practitioner. If we get on top of it, then we may prevent them from ever getting into the deeper part of the behavioral program.
It's a complex conversation. To run the ICU.
It is, and that's why, I would just keep caution that this isn't gonna be this isn't the be-all, end-all solution. This is just part of the solution, right? It helps, as you say, it helps alleviate that. If you look at what's in the HMA report, they spend a lot of time on this issue, and they recommend a lot of different community integration initiatives. So it's really gonna be an all-hands-on-deck approach, and this is just one of many solutions to look at.
Well, I think just to follow up on the conversation of integrating behavioral care, look at the models of community health centers that have integrated behavioral care that is being done by clinical social workers. There's a level of integrated level, that is being done, community health centers, and then transfer for more advanced mental health problems. So that would alleviate some of the issues with the providers, recruitment. And so there's many models out there that are successful.
Yes.
Just to be clear, we do have 8 embedded behavioral specialists in primary care practices.
Yes.
In
Yes.
addition to the specialty.
Yep, at those 5 practices. And I think it's working better at some locations than others, and that's generally a function of the layout of the facility. So that's one of those pieces you need to make sure you address as well. So you may recall this table from the last meeting. So we broke it up into the sub-markets to get a handle on your market and what the different markets look like. We looked at the different characteristics of the market in terms of the growth profile, the percent of the population that's at the poverty level, your ED market share, where you have sites in each of those sub-markets. And we actually ended at the last meeting with this table, which was we took that 98 number, and we're still sticking to that 98 even though we've kind of gone up a little bit, because again, this is just to sort of get a relative sense of each market and what the need is. This last column is what we've added. So then we took essentially where you have those physicians distributed now and where they're treating patients now, and we essentially backed that out from that distribution number. So what that helps to do is to highlight areas where you really have need. In other words, in some of these areas, like the southeast where you have 6 sites already, based on the primary care at those sites, you should have on your distribution model about 15 FTE of primary cares. You've got about 27 there now for a surplus of 12.3. So the word surplus isn't probably the best word to use. Let me show you what that map looks like. This probably helps as a better visual. When we say surplus, what we really mean is relative to all the other markets. So what's really happening here functionally, so in the southeast where you've got all of this, what you end up doing is all this sort of underserved population. So on this map, the blue is where the greatest primary care need is, less what you already have today, and it sort of goes all the way. So the red is, I'm using the term again, oversupply, even though it's probably not the best term. But essentially, these physicians are serving this population. So what you want to do is get physicians out here to serve that population. So eventually that may need some transfers. Remember as well, that doesn't mean you have too many docs here, because there really is a need there. And as we recall, your percentage of the population, and HMA covered this in their report, there's really a shortage in the market. So it's not like those guys are not busy because there's a surplus. They're going to be busy even when you add physicians out here. It's just that relative to where you are in the market, those are the greatest areas of need. So as you can see here, what kind of stands out is some of the southern region here, a little bit over here in that sort of White Settlement West area, the Northwest area, and then up here a little bit in sort of Keller grapevine, and there's sort of a lot of this light blue here. It shows some need. So this map is really the driving force of what we did. Well, actually, there's another map in here that came into play as well. But so then, this is the methodology we use to prioritize the zip codes, as I discussed earlier. So kind of some standard metrics: population size, population growth. You know, and we do this different for every health system. Given the population, your targeted population that you're focusing on, those below the federal poverty number, we doubled the weighting of that. So when we weighted all these categories, that had twice the weight of most of the other categories. We looked at the percent of families and then the ED market share. Now that those categories maybe aren't necessarily intuitive in terms of what you would look for in a site, but I sort of think of those as tiebreaker categories. In other words, if I have two areas that have essentially the same number of need for FTEs, I'm probably going to choose first as a priority the one that has a higher proportion of that population, because it's just more concentrated in that type of a community. So that would be what I would sort of call a tiebreaker between those two areas. Same with ED market share. If there's areas that are otherwise the same, but there's more of a need, then we're going to look at that one. Finally, is PCP need. That was what that last number was, that distributed need after you account for what you have. And embedded in that, the methodology to calculate that also had the federal poverty, so it actually further emphasizes that population as a target population. So let me show you the results of that, and there's 2 pages. This is the actual number of results, and I'll show you the map in a minute. So you can see each of the categories. So this is all on the zip code level. This is a sub-market definition that it was in, population of the zip, various statistics, primary care need, and then these were essentially their scores in each of the categories. So everyone was scored on a 1 to 5 basis, and then with a weighting, you came up with a weighted total. So Burleson came out on top. However, the reason that one has an asterisk is only 21% of that population is in Tarrant County. Now, I debated removing that just because I think it's an atypical zip code, but I think it's important to understand how that community is being served. And you maybe aren't the vehicle to serve that community, but nonetheless, you are going to get some of those patients. So I thought it was instructive to at least have it up here and know of that situation, even if we're not necessarily going to recommend putting something in that community, just because most of those, 80% of those patients aren't going to be eligible for JPS connection.
But we still do.
You do.
At least a third of our, we serve at least a third of these folks anyway.
Yeah.
Because I guess for the close proximity, we have to, so we have to prepare for it. So does this include any?
And you'll see that's actually, when we get to the recommendations, you're going to see that in one of the sites, at least, that is accounted for. Like one of the sites is actually going to create better access for at least the northern part of that population. So it's something we still recognized. I just wouldn't want to say that that's number one.
Yeah.
Is really the takeaway. It's not number one. It's somewhere on the list. You know, if I just took out a fifth of each of those numbers, you know, it would drop it way down the list. But, you know, I wanted to recognize that issue that you have with that population, so I think it's important to include it. But, you know, as we think about actually placing sites, you know, that's not going to be as important a consideration as others.
And also, since Burleson and Crowley are in such close proximity to each other, is that considered part of the conversation as well? Because Crowley and Burleson, I mean, they share. I mean, I live in Crowley, so
yeah.
You know,
well, and Crowley's almost all Tarrant, if not all Tarrant County.
Right.
Yes.
Exactly. So I'm wondering, but it's like next door to each, a street worth of difference.
Yeah. It did factor in, and Crowley actually was. I don't know if that's it. Yeah, there it is.
Yeah, it's down there. It's down toward the
Hold
bottom
that thought on Crowley, because there's
Okay.
going to be a solution to address that
Okay.
population. So.
Okay.
So what you're saying, there's only 21% of the 68,025
Correct.
actually
Right.
live in Tarrant County,
Correct.
right?
Yep.
So if you factor that out, then that rank
Should
Right,
drop
that would
significantly.
drop their population to, you know, whatever, less than 19,000.
Yeah, 20%
something
of
like
7 is
Yeah.
like 14,000.
that. Yeah.
I mean, you look at that, it will
Yeah,
drop
15,000.
out of the top 25 for sure. If you,
It probably would, yes.
right.
So again, and I thought about doing that too, again, but I just wanted to recognize that that population is going to go somewhere and it's going to be an issue you have to deal with. So I think just sort of shoving it aside wouldn't have been beneficial either.
Oh, I appreciate you mentioning them, because I think as a citizen, we want to acknowledge that they're suffering.
Again, it's really a question of then, you know, when you come up with a solution, right, this isn't the be-all and end, this is a major factor in thinking through it,
Sure.
but there are qualitative factors we have, and you'll actually see that, but I'll get to that in a minute, because there are other considerations, not just that zip code. That was a huge influencer because it really drives where the need is.
Right.
But you'll see how we've sort of then layered over qualitative factors on that. So if you look at the map then, this is the map of the zip codes. And it uses essentially the same sort of coloring system. So the blue would be the ones that would essentially have the biggest need. There are other towns I should mention that have population outside of Tarrant County. Mansfield, which I think some people perceive to be more, is actually only 3% of Mansfield is technically not in Tarrant County. So,
You know,
and there are others as well, but the other ones were sort of on the periphery that didn't really impact any recommendations. So I just didn't draw any particular attention to them.
and just to speak up for my little neighborhood, I live in
Sure.
76104 in the red, so we're not listed. So does that mean that we're not a priority because we're closer to the campus?
It doesn't mean that you're not a priority. It just means that, remember, the purpose of this is to identify where you need new sites. And so you have existing sites serving that. So that's, from strictly the perspective of new sites, you wouldn't be a priority. That doesn't mean that population is any less of a priority than anyone else, just that they have access right now. So this one, I think, kind of brings it all together. So let me take a second to explain this. So essentially what we did, though, was once, and we really looked at adjacencies with zip codes to sort of see, once you sort of factor in, remember that 10-minute drive time, and where is a site going to capture the most population of that needed population. So you can't just isolate a zip code and say, you're only going to capture people from that zip code. They're going to capture outside of it. So once we thought through those adjacencies, that really influenced where to make the most sense. So the way we essentially color-coded this, so after Burleson, this zip code, Fort Worth, which is right north of Crowley, right, in the southwest market, was really the #1 zip code. And then as we looked at that, we said, which of these ones on this list, and we actually went below the list too, because there's 66 zip codes, would start, if you put a site in that zip code, what would start to feed into that? So if you look at all the other red or sort of a burnt red color, those would essentially be all the sites. So all the reds are those sites. And the bold one is essentially, and this is just a preliminary recommendation, but it would be make the most sense as the center for a location for these sites. Now if you look at the next one in Mansfield, you know, that scored #3, but as we looked at the yellow ones, which would be all the ones that are essentially adjacent zip codes that have high need, it made more sense to put something in that zip code in Arlington, which is in the South Arlington submarket, to also serve the Mansfield population. So that was essentially the methodology we did here. Then you go to the green and northwest, in the blue, which is sort of north central, and then north central, northwest. And then essentially once you sort of add up that, we did this thing we call PCP score. Remember that need score, which subtracted what you already had. If you sort of bundle all that together, it starts to paint a picture. And if you see that, clearly the South Arlington site showed the greatest need just in terms of the number of FTE to serve that population. And then the other three were frankly, you know, all within more or less the same range, but all ranked pretty high. So again, those areas include zip codes not shown. There's the PCB score, and so we've covered that. We're going to go through each of these in detail, but I wanted to show you then what that would look like on the map. So I went back to this 10-minute drive time map, which we looked at the last presentation 2 weeks ago. So these red dots are essentially suggested new sites. Now again, we're just selecting zip codes, general areas. We're not here to tell you which building to go in. That's something you have to do down the road, and there's going to be many factors to consider. But as a sort of general location, each of those red dots cover that. So remember, in South Arlington, You've got that side. I'm going to cover all these individually, but generally in this area, this is, again, this would sort of serve that Crowley and North Burleson a little bit better. Some of them already get served by South Campus, but especially for the Crowley population, and that's on, what is it, Alta Mesa. This is in the white settlement area. This is sort of the Saginaw area. I'll give you some detail on each of those. So.
That's only for the next 5 years, right?
10 years.
10 years?
Yep.
Okay, that's a projection.
So, and that's a good thank you for the segue into the next one when we're phasing all those in. So as we sort of thought about what do we want to do, we're calling phase one the first 10 year, 2017 to 2027. And that really is, I would say the goal of that 10-year period is to improve access to those underserved areas. I think when you get those four, and there's a fifth that we're sort of on the fence about, which maybe will come into that 10-year period, which I'll talk about in a second. But I think, you know, if you hit those goals, and we even had a suggested opening date, and those are very fluid, very flexible, it will depend on a lot of factors, but just sort of thinking about how you might typically roll some of these out every 2-3 years. And then phase two would be 10 years out. Once you have those opened, I think you'd want to reassess your overall deployment footprint. And as you think about growing, that maybe at that point is probably going to include some expansion of the existing sites. So the solution 10 plus years won't necessarily be new sites. It'll be looking at expanding some of those existing sites, as especially as you said, in some of those areas where you do have sites, you know, that population is going to grow too. Obviously, I think the availability of financial resources will be a key factor in that implementation timeline. And again, after South Arlington, I would say those other three, you could really switch them in any order because they're all relatively close. So some of that just may be based on other factors, real estate opportunities, et cetera. So let's cover each of these. Do a quick time check. What time is it?
Is time?
2:09.
Okay, so we're okay. You said
It's
2:10,
2:10.
40 minutes in. All right, we're okay. South Arlington. So as you look at this one, so what we've done here is we've shown you the target area, which is highlighted. So all that red area is really the population that we would envision serving by a new South Arlington site. Now this one's a little bit different because this blue area is essentially that area we're recommending the site. So some of those major roads that go in there are Green Oaks, Sublet. You know, we use the Walmart there just because, you know, that's something that's heavily utilized by your population. It's kind of in the center of those. People know that. That doesn't mean you'd go next to it, but it's just sort of a flag to understand what the area we're talking about. So a lot of these areas too, which actually have some access. Now at the center of this, I think I have it, that's actually, believe it or not, a 15-minute drive from your current Southeast Tarrant site, which is also your busiest site. So you're at or near capacity there. So it is a pretty good distance. And then a lot of these patients which go up, some of the major roads actually flow in this direction, so that's probably going to be a better location for some of them. Now, Mansfield, you know, again, you know, you could make probably an argument for putting something down in there, but I think for this population, you're really increasing access. You're getting about 10 or 15 minutes closer for them, as well as serving other areas as well. The limiting factor with putting it in Mansfield is, you know, the sort of travel patterns go from south to north, so you want to be able to capture that. If you put it down there, those people aren't as likely.
They're used to driving north anyhow, so.
Exactly, exactly. So, Southwest ACC, so this is the one that captures that Crowley population, Alta Mesa. Some of this actually, I think in here is Burleson. The county line is right around that wishbone at the top there. I think it, if I'm not mistaken, I believe it is that green line.
I think so.
Now some of this too, you know, they do have access to this, but this population, there's really no easy way to get there, right? There's no diagonal road, so they have to go here, up highways, et cetera. So that's the South Campus location. That's really not a good location for a lot of people in this area. And this was, again, the #1 rated zip code up in here in terms of access, et cetera. You'll get some of that Benbrook population, but some of that Benbrook population to the west can actually go up to the Viola Pitts Center as well. And this site, again, 15-minute drive. I just picked the high school, the Kroger. sort of in that blue circle, and that's 15 minutes there. So again, you're sort of outside that primary care access zone. Northwest, this one, I think, of all the locations, there's probably 2 spots you could go here. So I think this would probably, once you get into the site selection process, you'd want to look a little bit more closely. But it's really getting access points for all this population up here. Some of this is a little bit more affluent population, but there's enough critical mass, especially down in this area of your target population, that it makes sense. And just, it's not an easy sort of get over to the to your Gertrude Tarpley site over there. So it's really not a part of the, it's not where that population goes. So something in here, either on Business 287 or in this area, probably one of those 2 locations would make the most sense for this site. Right now, this intersection, 287 Bailey, I mean, that's a 20-minute drive to Gertrude Tarpley, so it doesn't look far from, as a crow flies, but it's a long drive.
35 is a huge wall.
Yeah.
It really does not track east and west.
Yep.
There.
So, you know, my gut says this is probably going to be the more likely location, but
I agree. Yeah.
that would be examined further. Finally, there's the Northwest Central ACC location. So, again, this was the one you could kind of look. You know, you've got the base there with 2 different sort of areas you could consider for sites. You do have 2 sites sort of circling those, but neither one is particularly accessible, just in terms of road patterns, et cetera. You do actually own 11 acres, right about, it might be that lot there, but it's in this general area. Here you've got 11 acres of property, so that may be a consideration as well, because that would fit with that. If you do the one caveat I would add to this, the population numbers are a little bit smaller on this one. If you do go to that west, if you do go to this location, you're probably going to be on the small side of that range that we talked about. So that might be more of a 6 to 8 PCP site.
Have you looked at the need potentially to move any of the existing locations to the right spot?
Not necessarily. You know, we are going to have in the final report just some thoughts on existing locations, mostly from a consolidation perspective, but we did not do, say, for example, a condition analysis of any facilities if they needed to move. Again, we were really looking at this from an access perspective. I think there may be some opportunities to consolidate some of your, especially in southeast sort of central sites, but you're serving that population now, so that wasn't a high priority to this, and there will be some comments on that in the final report, but it wasn't something we looked at in great detail.
Thank you.
So finally then, there's the 15-year lookout. We call it the 15, it's really in that 10 to 20 year range of phase 2, so I just sort of picked the middle there. So what I did here was, I actually reran all those numbers. Remember, we had that distributed PCP. So in this scenario, I sort of said, okay, now we've got all 4 of these sites open, all 4 of those docs serving those zip codes. So all the scores for those ones are now going to tank because they're not going to have as much need, and that was really the primary factor. So if you sort of rerun those, so if you take that longer look out, you know, where then you're going to need a site, and really sort of 3 rows to the top. This HEB one, since it had so many in the top 10, and since you're sort of moving that new site a little bit further east, that west side of that submarket is probably going to need something right at that 10-year mark, if not earlier. What I would say is, you know, if you are successfully roll these out, I mean, that's not a hard line in the sand. If you have the resources to do that and the interest to do that, I would say that is the one that could potentially move up, especially as, you know, you've just opened that new site at the Northeast Health Center, so you want to track capacity of that. If that reaches capacity and there's long wait times within 2 or 3 years, then I would say you might want to push up the schedule for taking a look at that one. Then North Arlington, again, such a big population there. You've got Southeast Tarrant, not too far from some of those zip codes, those yellow zip codes in there, but there's going to be a need for that for another one at some point. And then finally, South Lake, you know, again, that is probably the most, and I just picked a middle spot there between Grapevine and Keller to the west. That is the most affluent part of your market, but at some point there is, you know, that target population does live there in pockets. and you're gonna reach critical mass at some point, and access will be an issue. So, you know, that's something I think you revisit in that time frame, but, you know, around then, it might be something to look at. So, next steps then, just finalize this report. It's gonna get integrated with my colleague Patrick and the coming team, so our team is gonna integrate that into the final report. And that is gonna include some of the specialty clinic needs. What we're really trying to do there is, you know, understand what you have at the Arlington site, what you have at Barden Clinic, and then, you know, it's some of the solutions for the campus specialty clinics are still somewhat, they're not exactly clear or defined yet in terms of the recommended solution for that. So those all really need to go hand in hand. So that's something we're going to be looking at and what we've commented on in the final report as well. So, additional questions? All right.
Thank you, Sam.
Thank you.
Appreciate that.
Thank you.
Okay, Ray, are you next up? I don't think you are. Yeah. Financial report.
I can hopefully not blow people out of the room here. Can you hear me with this? I got it. Are we on? Okay. Let me just put this here.
Take it out of the side of me. Reduce your solar works. It's gonna take a while.
All right, well, thank you for having me here today, and it'll be my pleasure to talk about some of the work we did in terms of the financial perspectives in conjunction with the work HMA did. This was really to provide obviously some context and support for the strategic planning process, and also for the delivery system and ambulatory and other work that we did as well. Doing this right here. There we go. So, in looking at the approach that we used on this, and it was kind of built around a SWOT, of strengths, weaknesses, opportunities, and threats, and then some observations and recommendations at the end. We started at the top by looking internally at JPS. They were great in providing us with a lot of information to support the work that we did. Then moving to the right clockwise here, we tried to benchmark them and assess their role within the county, so benchmarking them against other public health systems and looking at their role that they play in the county, which is obviously a significant role. Then we addressed some of the external pressures and other factors, and finally just talking a little bit about the delicate balance that exists for public health systems. HMA does a lot of work with counties across the country, from Cook County to a number of counties in California to really pretty much across the entire country. And I personally done work in 4 or 5 counties, and so what we're seeing is generally fairly consistent with the challenges that public health systems face. So we looked at JPS financial performance. We then did a breakdown of the JPS key revenue streams, which I'll talk about in a moment. We looked at the Medicaid supplemental funding streams, and we looked at year-over-year changes in activity levels. So to hit some of the highlights here, we looked at a 5-year period. I looked at audited financial statements, and I looked at changes over that period of time. From 2011 to 2016, JPS experienced a 39% increase in net patient service revenues, which is actually quite good. And 23% of that 39% came in the last 2 years, between 2014 and 2016. At the same time, we noticed that JPS's accounts receivable, the amounts that were due from a government and other third-party payers and individuals for the services that JPS provided to patients, actually declined by more than 7%. Which is really incredible given the increase in the net patient service revenues. What this really means is it's a tremendous improvement in what we call revenue cycle performance, which is the ability to collect the money that is due you for the services that are provided. One way to look at this is what's called days in accounts receivable, and that's how many days are outstanding of your revenue that have not been collected at any point in time. Another way that I looked at it was what we call accounts receivable turns. How many times does your accounts receivable turn over in a single year? And for that, you want a larger number. In 2011, 2012, 2013, that number was between 4.5 and 5. By 2015, 2016, that number was over 7. So the number of accounts receivable turns improved significantly. We also looked at year-to-year fluctuations in supplemental Medicaid funding, which I will talk about. But the bottom line is that's funding that is subject to somewhat things that are oftentimes out of our control. And there's also some recognition issues in terms of timing, which creates some challenges in terms of the way I might recognize it internally as a CFO, but the way that my auditors will require that I present it in the audited financial statements. And so we looked at it that way. We saw a cumulative increase in property tax revenue over the 5 years of 16%, much less than the 39% increase in net patient service revenue. So certainly that share with net patient service revenues did increase slightly during that time. And then we also noticed that there was a cumulative increase of 39% in salaries and related expenses, with the year-over-year increases being somewhat higher in the last several years. So this is the revenue breakdown of the key revenue streams for JPS, and this is very typical of public health systems. We saw almost 44% coming from net patient service revenue. We saw almost 38% coming from property tax revenue. And we saw over 18% coming from the Medicaid supplemental funding streams. Again, this is very typical. I've worked in 4 counties in California, a county in Arizona, and candidly, this is very consistent with what we see from those funding streams. With private facility, you would expect to get the lion's share from net patient service revenue, but for a public system, there's many challenges that they face that are distinctly different. This is the supplemental funding stream for JPS, and I picked this up from the audited financial statements. If you look at internal financial statements, they're going to run a little bit differently. Again, auditors can be very particular about the timing of the recognition in the audit financial statements. And so there can be some differences there. That exists in no matter what healthcare entity that you're talking about pretty much. But you can see it fluctuates. And that's a challenge. It's a challenge for JPS financial staff in predicting what the next year is going to be. But the reality is it's somewhat of an unreliable funding stream at times, but it's one that, for which the public health systems are very dependent. We also noticed, we looked at activity over the last 3 years, and this was based on internal financials that JPS was kind enough to share with us. There was a modest increase in terms of activity in non-nursery, non-skilled nursing patient days, comprised largely of a big increase in behavioral health, which is a very important area that JPS supports and provides services for, and a very slight decline in the acute non-behavioral health patient days. We also noticed a cumulative increase of nearly 15% in emergency visits over that period of time, and a decrease of more than 4% urgent care visits. And the combination of that is when we received a tour of the facility, we noticed there's some logistical challenges in getting from urgent care to emergency, and this is just one of a number of challenges that, quite frankly, JPS faces. They're doing the best with the facility they have, but it does create some challenges for them in terms of patient movement and that type of thing. And then, of course, skilled nursing was recently outsourced to accommodate the growing need for medical surgical inpatient beds. So this is basically a graphical representation of the emergency and urgent care activity that I just discussed in the previous slide. To me, you can see the emergencies increasing, the urgent care is off slightly. The thing that was most striking to me is between the two, if you look in fiscal year 2016, it's close to 180,000 visits. Okay? So between emergency care and urgent care, JPS is seeing almost 500 people a day, a calendar day. not a business day, okay? Every day, they're seeing on average almost 500 people. That is an incredible number, and it's really a reflection of the level of service that the JPS is providing to the community. But it's not without its challenges. It has challenges relating to facility, has challenges relating to delivery system, and it has some consequences. But certainly, JPS is doing a lot of the heavy lifting in terms of the healthcare delivery system. We also looked at benchmarking activity. We made comparisons to other Texas public health systems. We looked at the service footprint of JPS within Tarrant County and the role it plays compared to the other hospitals in the county. We're going to talk briefly about the disparate profile and the leadership that JPS provides in that area, and in particular JPS's unique role as a trauma center, because where it's serving patients in terms of trauma is somewhat different from what it is doing with respect to other lines of business. It has a much broader outreach on trauma, and we'll talk about that in a moment. So, we compared against other Texas public health systems. The public health systems sustain losses from services to patients. Compared to other Texas public health systems, the larger ones, JPS losses were significantly less than the systems in Houston, Dallas, and San Antonio, but slightly higher than those in El Paso and Lubbock. And, that's also mentioned on the next slide, which we'll go through in a minute. The uncompensated care costs were also much lower than those of the systems in Houston and Dallas, and slightly above those of San Antonio and El Paso. Operating expenses per adjusted patient day, we compared the 8 largest public health systems, including JPS, and we also added Brackenridge in Travis County. And when we looked at those, JPS literally was at the median of those 9 entities. And when you consider the last bullet, when you look at something called Case Mix Index, Case Mix Index was developed by Medicare as a reflection, the best possible reflection they could do, of relative complexity, severity, acuity of patients that a hospital is seeing. When I looked at this, and this came off the American Hospital Association database, JPS had a Case Mix Index for the most recent year of 1.85, which was the 3rd highest among all Texas public hospital systems, and higher than those in Houston and Dallas. So with a fairly high Case Mix Index, okay, you still got an operating cost that's at the median amongst the 8 largest public health systems in Brackenridge. This is the tabular breakout of the net loss from service to patients that I mentioned in the previous slide. You can see that JPS is significantly below the others. There was a dip for JPS as reported in the most current year from the prior year. I think the bigger picture is that this, with the American Hospital Association database, it's all self-reported data. But the theme is it's fairly consistent year over year. And I think the point that we wanted to make is that JPS has the challenges that other public hospital systems are, but given the size of the community it's serving, that its losses were quite modest compared to some of the other larger health systems. We also were able to get some data from the Dallas-Fort Worth Hospital Council. And we looked at that in terms of the level of activity. They provided the data to us. This ultimately came from the hospitals. And we asked them to provide 3 groupings of data. Tell us about emergency department inpatient admits. Tell us about emergency department outpatient visits, meaning treat and release. And tell us about non-emergency department outpatient visits. And then look at those 2 ways, one in total, and one for those where there was a behavioral health diagnosis or need. When we look at, and we had them also cut it for adults and children, so 18 and over and under 18. And really, for all these categories, JPS, in terms of activity levels, was either number 1 or number 2, with the exception of the emergency department outpatient visits for children. and the non-emergency department outpatient visits for children, both where Cook Children's was number one, as we might expect. I think the bottom line in all this is that the role that JPS is playing, to me, is pretty clear, and that it's a significant provider of services when you look at emergency and non-emergency department activity, and especially with adults, but even with children in the emergency inpatient admits category. So it's, JPS is a mainstay provider in the county. This discusses a few of the individual categories for which we provided the rankings on the previous chart. For the 12 months ending September 30th, 27, excuse me, that should be, by the way, for the fiscal year ending 9/30/16. I apologize. JPS saw more than 110,000 emergency department visits for those over age 18 over, second only to Texas Health Resources, Fort Worth. More than 17,200 emergency department inpatient admissions for those 18 and over. More than 7,200 ED inpatient admissions for children, second only to Cook, and more than 1,200 behavioral health emergency department inpatient admissions for adults, again, more than any other facility in the county. And if I go back to the American Hospital Association database, based on the numbers reported for uncompensated care, JPS had 3 times the amount of any other hospital in Tarrant County. So in terms of DSRIP, JPS has really been a leader and a partner for both the Delivery System Reform Incentive Payment Program and for the uncompensated care in Tarrant County. It serves as the anchor for the Regional Health Partnership for Region 10, which covers Tarrant and 8 other counties, I should say. JPS has 27 active DSRIP projects that include everything from improving access to care, integration of primary care and behavioral health, which Sam talked about a little bit, disease-specific projects, and coordination with other regional providers. And it provides significant funding on behalf of its private partners as well, putting up the non-federal share of intergovernmental transfer arrangements, which are the ways to draw down some federal money. And then just briefly in summary, this was provided by JPS. These are some of the net delivery system reform incentive revenues that JPS has received. That's part of that Medicaid supplemental funding revenue that we talked about earlier when we showed the pie chart. That's part of that number. So let's talk about trauma a little bit. There are 17 Level 1 trauma centers in the state of Texas. Many of them are in the central to southern part of the state. If we look at the northern and the central part of the state and looking west from there, only Lubbock and El Paso have Level 1 trauma centers to the west of Fort Worth, west of JPS. San Antonio slightly west, but it's much further south in the state. So when we look at the distribution of the population, the distribution of trauma centers, there's not a lot of service to the west, and you have to go quite a ways to the west to see other Level 1 trauma centers. So given that reality, given the distance between Fort Worth and Lubbock, for instance, it's not surprising that JPS provides trauma care to a number of residents in counties other than Tarrant County. Just as a way of example, we looked at a number of service lines. We looked at neonatal, we looked at maternity, we looked at emergency in general, we looked at behavioral health. About 85 to 90% of the services that JPS provides for those service lines serve residents of Tarrant County, and only a small percentage of residents outside the county. For trauma, 42% of the trauma inpatient charges, 38% of the inpatient discharges, and 30% of the trauma outpatient charges were incurred on behalf of patients who did not reside in Tarrant County. And that's somewhat of follows from what I mentioned earlier about the distribution of the Level 1 trauma centers throughout the county. 5 of those of the services provided outside of county, 5 counties represent slightly more than half of inpatient trauma services provided to people that did not reside in Tarrant County, and those were Johnson, Wise, Parker, and even Dallas and Hood counties. So you've got people moving between counties depending upon the the services needed.
Excuse me, sorry.
So let's talk briefly about some of the external pressures and then the Texas Medicaid waiver and a JPS connection as well. So I think it's safe to say there's a lot of uncertainty right now as to what's going to happen with the Affordable Care Act and either a partial or full replacement or a modification, whatever that might be. That will affect both the Medicaid expansion program, and even though Texas did not expand Medicaid, there's still some impact there that could affect the state, and as well as the insurance exchanges where Texas did try to adapt part of what is in the Affordable Care Act. We're also saying that the Texas Comptroller's Office is estimating that revenues, biennial revenue estimate is just under $105 billion for 2018-2019, which is down slightly from what was estimated for 2016-2017. That could impact JPS Medicaid funding and other hospitals as well. The percentage of uninsured in Texas has declined from 2010 to 2015 from roughly 24% to 17%. Texas still has the highest uninsured rate in the nation, as well as one of the largest unauthorized immigrant populations. And those two are very directly related because many of those people will never be able to qualify for Medicaid or exchange coverage. So that's an impact as well. Texas overall, and Tarrant County in particular, are expected to continue to experience significant population growth compared to other states. As you all know, that Texas is the second most populous state in the country, and is probably growing at a more rapid rate at this point than the state that I come from, California. And I think all our projections from what we showed in the report would indicate it's going to continue growing at a significant rate in the coming years, as is Tarrant County. And although Texas accounts for slightly less than 9% of the U.S. population, it does account for roughly a quarter of U.S. hospital closures since 2010. So there's an impact here in that hospitals are feeling a lot of pressure in general from uninsured and unfunded care, and that's probably what you're seeing in those numbers.
Do you know what the distribution is on that from rural hospitals to urban hospitals?
I do not. I'm sorry. That's
Predominantly rural.
Because I think the rural is going to be a little bit disproportionate on that. Those hospitals have nothing.
Right, and that, by the way, while I don't know what the distribution is, your comment that it's predominantly rural is clearly understandable because they don't have the resources.
Right.
There's they don't have a margin of safety.
Right.
Okay, that's the biggest challenge that they face. So, I think that's a reality that we're going to continue to deal with. And because Texas is such a large state geographically, you're going to have a number of rural areas, and they will be impacted. Nonetheless, it's a concern of some level, but it has a lesser impact on this county.
Well,
the trickle down effect will be those rural communities outlying.
Exactly.
Yeah.
Exactly.
And the extent then is the folks have to travel a ways to get additional care.
That very area that you were describing before, out west of here, is where you find some of these marginal hospitals that are barely hanging on.
Right.
And so that population now even has more reason to come down here.
Right, and not only do they not have let's say, trauma facilities, they may not even have great access to emergency care in general.
Yeah.
So the Texas 1115 transformation waiver in 2011 was developed, and the federal government approved it for a 5-year period. That was approved 6 months before the Supreme Court ruling that effectively made the Medicaid expansion optional. But the CMS, Centers for Medicare and Medicaid Services, did approve it, and it was based on the assumption that Medicaid expansion would ultimately occur in all 50 states. The waiver budget for the 5-year period was $29 billion, of which $17 billion were anticipated to be federal funds gained by Texas over the 5-year period. Uncompensated care and delivery system reform pools each made up about 50% of the total, at least in the later years of the waiver. There is a portion of the UC funds pool that may be at risk And a lot of that will depend on the future decision in terms of what the feds do in responding to Texas' request on the waiver. In 2016, the CMS did grant Texas a 15-month extension of the waiver through December 31st of this year. And in January, I believe it was, of this year, the Texas Health and Human Services Commission submitted a request for an additional 21-month extension, which would take it through September 30th, 2019. The request was to continue the level funding for the DSRIP and UC pools with the current 15-month extension. It would also allow time to get through the next biennial session of the Texas legislature. JPS Connection. JPS Connection is really a community resource. And we looked at data for fiscal year 2016 because we wanted to really see the way that this program reaches out and the services that it provides. It is a significant payer category. We looked at internal data for this because sometimes when data gets reported externally, the external sources that report back don't recognize JPS connections separately. So we used internal data, and essentially you can see the range of services, the percentages that JPS accounts for inpatient, psychiatric, emergency, non-ER, clinic, and outpatient. You'll notice in particular that for the more ambulatory services, the percentage was even higher, which means you're doing a great job in reaching out and having a JPS connection be something that is there for people to get some basic care, to big clinic and ambulatory care. And what Sam was talking about, I mean, a lot of the emphasis here is if you move towards population health, you want to move towards a delivery system that is a little more balanced and that allows ambulatory care and outpatient-centered care to be more available. Certainly, we've been making that available through JPS Connection. It has an opportunity to do more, but not without funding. In other words, right now it's doing a lot, but to expand the eligibility on JPS Connection without providing some funding to support that would not really, at this point, make sense from a pure financial standpoint. Yes.
How much revenue have been expanded for the JPS connection on an annual basis? Approximately, do you know?
I don't know that. I don't know that offhand. Although my understanding is, and maybe Sharon can answer, but I believe it has consistently gone up over the years. But I don't know, Sharon. I don't want to put you on the spot. Do you know that?
There's been a slight inflation factor for that, but it just I think you can probably hear me without the mic, but there's been a slight inflation factor that has increased with the connection program expenses, but there has not been a major program service expansion in the last few years.
What I'm interested in is a specific dollar number in relation to the overall budget of the hospital. I think that ratio would tells us significantly.
The ratio of JPS Connection is % of the total revenue budget?
Cost.
Okay. Okay.
Cost.
You're looking at cost.
Yeah, how much money we spent to support and sustain the JPS connection in relationship to the overall cost of JPS. Right. Does that make sense?
It makes sense. I don't have that number off the top of my head, but
Ballpark, like, I'm gonna say 150 million.
Yeah, it's 15%, 20%, something in that range.
well, and that would be consistent. If you look at these percentages and where the big dollars are, they're emergency, acute, inpatient, whatever, but they're raised by the outpatient somewhat. So it's to say it's in the mid-teens is a percentage, but again, that's not a cost finding.
Right.
But it gives you some general sense of the significance of the program.
Okay. Thank you.
So on the pie chart that you showed us several slides back, it had the
Yes.
three sources.
Yes.
This would be in which part of that pie?
To the extent that we received payments from patients on that, it would be in the patient revenue side.
Okay. Yeah.
Okay,
It would be considered an insurance.
But those are significantly. I mean, there's the amount of care that is provided at little or no cost is involved in that too. those services are,
Yeah, I'm just trying to figure out of that slice of the pie, how much is this?
of that slice of the pie.
It's a hard way to look at it.
Yeah, the cost side is much higher
It's
than the
cost
revenue side.
It's really more like uncompensated care. really.
Yeah, as a cost side, these percentages probably get you in the ballpark. As a revenue side, it's going to be a very small percentage because we're providing, JPS is providing services at either little or no cost to the beneficiary.
This is where the taxpayers' money go to, pretty much, right?
You can look at it that way, but I just don't want to lose sight of the fact that public health systems, whether they have a program called JPS Connection or Connection, or however they provide services, they're providing a lot of care at little or no cost to the beneficiary. For JPS, a lot of that is done through the program called JPS Connection.
Right.
And some of it is just uninsured care that is written off
Yeah, and
separately.
if you look at connection as really a pre-screened qualification for uncompensated care, that's really the best way to look at it. It's not insurance, we're not getting reimbursed for it.
So a person, again, I don't argue, I'm just trying to clarify. An individual walks into the John Peter Smith ER, is not part of JPS Connection. That is uncompensated, and they're not insured. In the pie, they are in the uncompensated section, is that correct?
Well, again, the pie was based on revenues.
Right.
So if we're not collecting, they're a patient service, and to the extent that JPS receives reimbursement through the uncompensated care pool for the uncompensated care it provides, that may be influenced in that 18%.
That's what I'm talking about.
Okay,
Yeah.
but in terms of patient services, it's in that 43%. But the problem is it's uncompensated.
I understand
Yeah,
that part. I'm just trying to figure out that person,
Right.
just from an accounting standpoint, that person versus the person that is signed up. I'm just trying to figure out where they end up at the end. They're both uncompensated, I get it.
right.
Okay, but one's going to get a little bit of compensation via the state programs, everything that's in there, but it's that other one that's not signed up for anything. Where does he or she show up after they've gone through the whole system?
Right. Well, again, it's a patient service, so it's in terms of the revenues, there's no
There'll be
revenue.
no revenue.
There's no revenue, but it will probably generate a certain percentage of supporting the uncompensated care pool
Correct.
and generate some revenues that way. So I guess the response would be it's in that 18%, but it's the cost side that is, I think, is
understand
bigger.
that part. Yeah. Okay.
So if we look at the totality of this, public health systems fill the care gaps, and JPS certainly does a great job of doing that. We're going to talk a little bit about JPS percentage of the Tarrant County payer mix. I'll get to that in a moment. We're certainly serving the uninsured and the underinsured. Public health systems need help in covering costs, and one of the goals here will be to leverage capabilities for population health, which we've talked about a little bit. So this data comes from the Texas Healthcare Information Collections. This is the third external data source that we utilized in doing this. And this was a roll-up of data that was put together for us by someone who had access to this database. And it looks at total, it's not JPS focused, it's really focused on Tarrant County residents in total. And it takes charges, and by using cost to charge, what we call cost to charge factors, it tries to convert them to costs. And then it looks at what's the unfunded costs of various lines of business. So if you look at what was the number one diagnosis or disease state, if you will, that for which there was unfunded costs, mental diseases and disorders was first, substance use or induced disorders, multiple significant trauma, okay, and then you see some other services here as well, that many of which are individuals that wind up in the emergency department. I think the point that I wanted to make with this was that if you look at the certainly mental diseases, disorders, and multiple significant trauma, these are services that disproportionately provided by JPS. Okay, so once again, if you look at the unfunded costs, JPS is doing some really heavy lifting here in terms of the services that it provides. So that was really the main focus of this slide. This was another look from the DFW Hospital Council data. And what we did with this, we looked at revenue categories: inpatient insured, this is by payer mix, inpatient Medicare, inpatient Medicaid, inpatient uninsured, and then the same categories for outpatient. And we said, what percentage of the Tarrant County total does JPS account for in each of these categories? So JPS, for instance, JPS accounts for only 13% of the inpatient insured and only 6% of the inpatient Medicare, but accounts for almost 22% of the inpatient Medicaid and 32% of the inpatient uninsured. So when you, again, it's another look, and no statistic or number is perfect, but we try to look at this as many different ways, and we really kept coming back to the same thing. And when you look at the outpatient uninsured number, it's almost at 40%. So I put those in a red font just to kind of highlight them. But once again, it's just another indication of the work that JPS is doing on behalf of the county. This looks at internal data again. So once again, we looked inward. This is data that looked at inpatient, mental health, and emergency department. And we looked at we really looked for a JPS payer mix snapshot for those three categories. And you can see that for all three columns, there's a pretty significant amount of work that is being produced by JPS on behalf of these either underinsured or uninsured patients. You can see the emergency department, 40% payer mix self-pay, and another 14% JPS connection, and another 17% Medicaid. So pretty significant percentage. This takes, if I go back, that last column on emergency department, if I take that and I put that into a pie chart, that's what it looks like. So it's just a pictorial view of that last column. But again, it kind of visually highlights what we were talking about. So one of the challenges that public health systems have, and I haven't encountered a public health system yet whose net patient service revenues from services to patients, cover even its labor costs. I haven't seen one. And JPS is no exception. You can see that the shortfall of net patient service revenues compared to labor costs is increased slightly over the past few years. But this is one of the challenges that public health systems face. And that's why, if we go back to that pie chart we talked about earlier, that's why we need those other two parts of the pie. We can't get by with the one. And it's just the reality. But again, this is very consistent with what I've seen. I will tell you that I think our property tax revenues are something in excess of $300 million in support. I won't name the county or even the state, but I did some work 4 years ago for a county, and that county at that time, from its general fund, was putting up about $500 million, and this was back in 2013 or so, for a population that is probably less than half of what the population in Tarrant County is. So, just to provide some perspective, and I think that it's just gives you an idea of what the challenges that are faced. Here's the kind of a summary of overall what I think that where JPS could help in moving more towards population health, which I think would benefit the community and also benefit JPS. Clearly, JPS is a robust array of services, from emergency and trauma to behavioral health to many clinic specialties to neonatal intensive care, other tertiary and acute care services. It may continue seeking potential partnerships that involve complementary adult and pediatric services. I know that there's already been discussions in the past, I believe, with Cook. In addition to addressing the facility needs, or in conjunction with with addressing the facility needs, One of the things that and what Sam talked about is elevating the importance of the ambulatory care within the context of the delivery system. Also supporting perhaps the expansion of the FQHC network and continuing moving along the line of what are referred to as patient-centered medical homes to position for value-based payments. So I'm a 22-year hospital person, and I work for hospitals mostly in the era of fee-for-service, volume, more is better. And we're moving away from that to a which I think is positive, to a value-based system. And with a population health environment, focus more on the front end and hopefully keeping people. We need the hospital services, but we don't want to provide hospital services to somebody whose hospitalization could have been prevented or whose emergency department visit could have been prevented and whose life we might have positively impacted by having more ambulatory and other community-based services. So I think that's part of what I see as the focus here. So let me talk a little bit about just some high-level conclusions on the SWOT and observations. Again, highlighting, we mentioned this earlier, JPS's net patient service revenues have been strong over 5 years, and its accounts receivable management has been very good over the past few years. It ranks first or second in Tarrant County in many of the categories that, in terms of activity levels that we mentioned earlier. It provides more than 3 times the amount of uncompensated care as the second highest hospital in Tarrant County. It has the 3rd highest case mix index of all public hospitals, with an overall readmission rate that was only slightly higher than the Tarrant County average. This is something that Medicare looks at, readmissions. And finally, it's playing a critical role as a leader and the anchor of the 1115 Transformation Waiver Regional Health Partnership Program. In terms of challenges or weaknesses, salaries have gone up a fair amount over the past few years, but it's really that gap. It's the gap between the net patient service revenues that I mentioned earlier on that chart and the salaries that is something that public hospitals are facing. Other than neonatal intensive care, JPS does not have a real strong pediatric footprint, and which may inhibit its ability for Medicaid contracting. This speaks to the issue of, again, developing partnerships with Cook and others as well. It has not had a operational productivity or cost accounting systems, although in speaking with Sharon, I know these are well under development. I think the bottom line here is you can't improve what you can't measure. And we know that, and this is a big step. So there's an opportunity there, and JPS is already seizing on that opportunity. JPS has little experience with capitation or value-based purchasing. This is kind of the direction where the world is moving. So this will be something that they'll want to get more involved with. But they need to do this in the context of the strategic plan, in building the ambulatory centers, in their contracting processes, in their partnerships with the private sector. And there's a lot of opportunities for public-private partnerships here, and some of which you've already availed yourself of, but there may be additional ones as well. The current layout of the hospital does contribute to the existing inefficient use of human resources in many places, so that does have a serious and real impact on costs. And the lack of private rooms and more efficient facilities does impede the facility's ability to maximize revenues, improve operational efficiencies, enhance quality outcomes, maintain infection control. If you have private rooms, for instance, your infection control problems go way down, and ensure regulatory compliance. In terms of opportunities.
Question over here.
Yeah.
Under weaknesses, you talked extensively about clinics, but you don't have a meatball for clinics under weaknesses.
I beg your pardon?
You didn't mention anything about the clinics under weaknesses, and there's obviously a real deficiency in the clinics.
You know, your point's well taken. I probably phrased it more from a standpoint of we need to build out the ambulatory system. So I think your point's well taken. Hopefully I captured that in talking a little bit about the need to move more to ambulatory, but I agree. So again, in terms of opportunities with a more contemporary facility, JPS could improve its market share of Medicare exchange and private sector revenues. Certainly, it has the mission infrastructure to accomplish what it needs to accomplish. I know it is working more to develop some managed care relationships, and there's been some discussion with Cook. Again, the productivity and cost accounting systems are in the process of being implemented. There may be opportunities with the employee medical plan as well for the benefit of employees and to drive additional business to JPS. There may be opportunities with trauma. I think a case could be made, and could be controversial, but I think a case could be made that working with the state and with other counties, given the amount of work and trauma care that JPS is providing to residents of other counties, there's a case that can be made that there should be some compensation or funding that comes from others to support this. And I think that's something that at least should be discussed. It's not a simple solution, and not everyone will agree, but I think you have a valid case that, given the lack of level 1 trauma centers, that's something that is worthy of at least a consideration. And then the state, with support from the governor and legislative leadership, has requested that CMS approve the existing structure of 1115 waiver through September 2019. Hopefully that will happen. I guess we'll just have to wait and see.
Getting back to the counties that don't have a hospital that use our trauma system, have you seen some situations in other states? Obviously, this sort of relationship occurs in other places where they were able to create a funding mechanism from those counties to the predominant recipient of those patients, or is it just one of those?
It's so I live in Southern California, which is a megalopolis, okay. But you get up into Central and Northern California, there are many more rural areas. I'm not familiar with all. Some of these things can sometimes be addressed in state waivers, but this is a situation that may be, quite frankly, outside a waiver issue. It may be just a case of just basic access, regardless of the funding source. Now, some of the folks maybe coming from other counties may have some funding, but there's a pretty high. When you looked at that chart I showed from the Texas Healthcare Information Collective, that showed that mental health and trauma were amongst the highest unfunded costs. Okay, so clearly a good part of what's coming from other counties. I'm not aware of any. Back to your question, I'm not aware of any specific arrangements, but I think given the size of the state, the reality of the unique place that Fort Worth and Tarrant County and JPS occupy in the geography, Dallas County was one of the top 5 counties outside the county, and they clearly have trauma centers. So there's some of that, but also the thing is they're buffered from the west by JPS in a way, right? So they don't have the same challenge that you all do, and I think it's worthy of a discussion. Can I tell you of a specific plan? I can't. I'm really sorry, but I still think it's worth a discussion, and because I think it needs the awareness level of the good work that's being done is worthy of being raised. Would be my comment.
It's really a legislative issue too. I think I'm sure Lubbock would be all in favor of it,
Yeah.
and so would El Paso. And they're probably getting patients from New Mexico.
And they all would. You bet. Yeah.
The other thing, I think if we keep in mind that absent some direct ability to recoup those costs from neighboring counties, it puts even more emphasis on the DSRIP program, because at least through the DSRIP waiver program, we're able to amalgamate some of these programs from other counties and be able to generate some dollars from the Fed. But it's difficult to come up with a direct means of being able to compensate that.
Yeah, and there may be creative ways, depending upon what happens with the waiver and depending on what happens in the future. There may be different vehicles, if you will, to accomplish this. I think that the essence is that it's worthy of receiving additional funding for the work that you're doing. So certainly, let's see. I think we cover this. Yeah. So in terms of threats, non-replacement of the hospital has some risks. It could impair JPS' ability to maximize reimbursement, improve patient satisfaction, private rooms have pretty much become the standard of care. Enhance quality of care, meet regulatory requirements, improve operational efficiencies, and support training and education. There is some uncertainty with the waiver right now, so that clearly is a threat of sorts. Also, within Tarrant County, JPS is one of the top 2 behavioral health providers and serving a pretty wide geographic area. It is at risk of being overwhelmed unless capacity is addressed, and certainly capacity has been increased to some extent in behavioral health, but I think this will be a continuing issue as we as a nation are becoming more acutely aware of the issue of mental health and substance use in this country, and it's something to be looked at. And again, the renewal for demonstration years 7 through 10 still has some level of uncertainty. So some key observations. JPS is a safety net leader in the county in terms of disrupt and uncompensated care. It is providing it's a significant and critical provider of emergency and behavioral health services, particularly for those who are underinsured or uninsured. It's a critical provider of trauma care both within and outside Tarrant County. Its revenues and expense profiles are very typical of public health systems. So, I mean, we really looked at this. I looked at 3 external databases. No database is perfect, but I looked at this 3 different ways externally. I looked at internal data. I used the experience that HMA has had and I personally had with public health systems to look at this, and I'm very comfortable that you're facing the same kinds of challenges that others are facing, and probably doing better than many of them. So I think that's very positive. Existing facilities are an impediment to JPS to operate more efficiently and to transport patients into triage care, and you want to attract a broader range of patients. Clearly, no one's denying the fact that JPS is going to serve a number of uninsured and underinsured people, but a little more balance would certainly be, I think, a positive impact there. You've demonstrated positive improvement in revenue cycle performance. I think that's worth mentioning one more time. And there are opportunities to focus on collaboration, which you are already doing. We're just really encouraging that. If you go with the distribution of the ambulatory sites that Sam talked about, that will go a long way to maybe mitigating what otherwise would have been some transportation issues. I still think there may be some opportunities as a county to collaborate in public-private partnerships on transportation. That will be something I think that can be addressed later, but certainly the expansion on the ambulatory side will go a long way towards addressing some of the concerns I think that we had. In terms of financial recommendations, again, we encourage the strategic and financial planning to focus on maximizing reimbursement. The facility designs not only need to be patient-friendly, they need to be efficiency-friendly. I've seen situations where new facilities were built and the layout with the nurses' station was less conducive to efficient care than it was then in the old facility. So again, I think now more and more, I think what you're seeing in facility design, thankfully, is a lot of attention being paid to how can we make it more efficient and effective in looking at it from both the patient standpoint and the caregiver standpoint. Again, the comment on trauma, again, I think it's something worthy exploring in terms of funding from other counties or through state grants. Continue working with the state and your participating DSRIP and uncompensated care partners in developing value-based models. So DSRIP and uncompensated care could be reshaped a little bit conceivably, depending upon what the capabilities are. But maybe if there's future DSRIP initiatives, maybe those can be more geared towards achieving some of those objectives. Continue the discussions, the collaborative discussions that you've already undertaken with Cook and others, and pursue the continued discussions between the county, JPS, and the private sector in terms of transportation. So that's my presentation. I'm happy to answer any questions that you might have. Yes. Is there a question?
Yes. No. What's your question?
Where do we get the money to do all that? I'm sitting here and I'm listening to you and I'm thinking, okay, we've got to spend money. In my mind's eye, I'm thinking about Dr. Video down there with all the clinics, the community clinics, so we can expand those. But that costs money. So what, beyond getting better reimbursement, the federal government, I think we just kind of, as a retiree, throw it or what? I mean, just put it on the side bar. You don't want to increase taxes. We may have to at some point. So how else can we become do all the things we want to do with less resources? What do we do? Have you come up with a creative model in public health that could help fund us so we...
Well, I will tell you candidly, and this is why I gave you tried to give you the perspective of JPS and other public health systems, because the things we talked about today and the good questions that you're asking are not unique to JPS. I mean, you have unique issues, but the challenges that JPS faces as a public health system are pretty extensive across the state and across the country, and this is what systems are facing. And I think what a lot of communities have looked at is they've looked at their public health systems as a public and community resource. And the private sector, I think, has a vested interest in this as well, because JPS is doing a lot of good work that somebody is going to have to do. And so I think there's an investment to make. From my standpoint, I don't have the magic answer to your question in terms of how are we going to get it. I mean, ultimately, again, it's a public resource, it's a county resource, and you're serving people in a county that is got a pretty good growth rate, in a state that has a pretty good growth rate. So, I don't have the magic pill or magic answer here, but I think it's it's worthy of an investment. Now, that's the next discussion that you all are going to have. But I think we've tried to provide I tried to provide some perspective for where you are and what your reasonable expectations are and how you're performing. And I think you're playing the hand you've been dealt about as well as you can reasonably play it. And so now the next step is, where do you go to invest more? And how are you going to do that? And nobody wants to see their taxes increase, but I guess that's a further discussion for this group. And I think that I've tried to give you some context for it. Yes.
Any other questions for Ray?
I noticed that.
Let's get your microphone.
Gerald Lukaska. I noticed that you didn't say anything about CMS, MACRA, everything that primary care physicians like me are going to have to deal with in the next few years is going to decrease productivity. I don't see any way around it. The other thing is that if you consider that Texas has the second highest percentage number of physicians who are private, they're not corporate physicians, they're private physicians, you're going to have, you can talk all you want, but you're not going to have anybody to do the work. I mean, you say we need access, we need to improve the number of people that we see. When I started practice, we were seeing 35 people a day. When I retired, we were seeing 17 or 18 and working twice as long. Everything that I see coming down the line is going to decrease productivity of the people that you need to improve productivity. And I don't see that you factored that at all into any of the discussion.
Again, my goal here wasn't to tell you what the financial pro forma would be for the next 15 to 20 years, but I hear what you're saying. And with attempts to improve quality have become increased regulation, which I think is part of what you're addressing, if I'm hearing you correctly. Attempts to You're saying you're doing more administrative work, is that what I'm?
About 50% of your time is spent doing
Okay,
administrative work.
okay. And that's not, and I've heard that comment before. My focus today was on the public health environment. I think what you're talking about is broader than just that, by the way. And I don't know, I don't have the answer for.
What I'm saying is that somebody's going to have to do the work in the end.
Right.
Somebody is going to actually have to see the patients, and you're not going to have enough people to see
Right.
them.
Right, and I think one of the things that's happening, and is that they're trying to get people to operate at the top of their license. So there are nurse practitioners, there are physician assistants, there's RNs, and you're trying to ease the physician's burden to a certain extent. But that has limitations as well. I think the bottom line is that we're trying to see how we can get others to operate within their license, and maybe the physician can push off some of that work. I don't know how much of your time you're spending on electronic health records or how that's helping you or not helping you, but certainly that was an attempt to hopefully ultimately make the system work better. I've heard varying results on that.
Questions? Okay, Ray, thank you. I think we probably need maybe a 5-minute break here. Everybody needs to get a little stretch, a little oxygen in the system. So
Excellent idea.
go ahead and do that.
That's the best idea you came up with all day, right?
I've been working on that one.
Sure, make this fun.
Make it fun.
Oh, every moment is fun.
You have to make it fun.
Got a little drowsy here.
Sorry.
Doesn't sound very
Kind of
medical.
starting to make me
The most fun I'm gonna have is that it's
shorter
20
than
minutes. How's that for fun?
Yeah, his was 34 slides, yours is not.
It is not, and I don't
Okay, let's
plan
go ahead
to
and get
cover the
started, y'all.
small
That's
print.
good.
How are you doing?
Haven't seen you in a long time.
I know, it's been a while. Good, very good.
Okay.
You snuck in later.
Okay, so we are going to go to Sharon's report, but before we do that, Scott wanted to make sure that everybody on the committee was aware of a recent announcement today that we should all be pretty proud of.
Yeah, Robert Early called me last night and asked me and the other former chairs of the board to be there this morning for the announcement. Modern Healthcare announced today that JPS is one of the top places in America to work in healthcare. And there were only 150 locations nationwide. JPS is the only public hospital, is the only major hospital in Texas, the only organization in Tarrant County, and the largest in the entire Metroplex. Huh?
You know what the secret is?
Leadership.
And cookies.
Everybody gets cookies.
That's right.
That's right.
No,
Congratulations.
it's a huge
That is
deal.
a big
It's a big deal.
For
Big
any
deal.
hospital.
Especially the turnaround since 08.
Thanks, Scott. Appreciate that. Well, on that note, we'll just get to one of the other stars down there, John Peter Smith.
Thank you. Thank you. I have introduced myself to most of you this afternoon. If I have not met you, my name is Sharon Clark. I'm the CFO at JPS. And Friday, I will have completed 2 years at JPS. So I'm relatively new there. Thank you. I'm very proud to say that I've completed my 2 years. It's been a pleasure to be back in Fort Worth. A little bit about JPS. You stole a little bit of my thunder.
I'm sorry.
That is fine. That is fine.
I got here late and I asked if they had said anything at the beginning.
That's good because it's a great segue about who we are. And I'm really excited to be able to come here today. I was asked to prepare about a 15 to 20 minute slide deck for you, not on specifics of financing or anything, but just a very broad overview about where our money comes from and where our money goes today. So that's the purpose. There are some pages at the back that have a lot of numbers on them. I really don't plan to talk about those today. I really tried to get some nice pie charts and some colorful graphs because finance is sometimes overwhelming and boring. So I did try to remember my audience today. We can dive in if you want to, but I'm not planning to go too deep. So this is one of my favorite slides because it kind of shows our facilities. I don't know if you've seen that in any form before, but the facility that most of our patients are in today is either the one that opened in 1971. I don't know where I was at in 1971. I know where I was at in 1985. 20% of our admissions and our psych inpatient are in this facility. And then our ICU patients and our ED are in the facility that opened in 08. That's across Main Street. So just a perspective of when those opened up. So our destination metrics, every company has a mission statement. Most healthcare facilities have something similar to pillars or what we call pillars. But I think something that makes JPS unique and our decision making are what we call our destination metrics. And these things kind of drive our decision making. They help us prioritize projects. These 9 things have been approved by our Board of Managers. And I just wanted to show you these. They talk about our patients in the safe environment of care. They talk about patient satisfaction and HCAP scores. They talk about leading workplace culture, which was a great segue. We announced this morning that, and I'm going to read this because I haven't familiarized myself enough with it, and it's such exciting news. We were awarded Modern Healthcare's Best Places to Work in Healthcare. Only 150 facilities across the nation gets this. We were the only public entity in Texas to receive this. We were only one of 2 publicly supported hospitals in the nation to receive this. There was one other one in California. We were the only hospital in Tarrant County to receive this award. We were the only hospital system in DFW to receive this award. So we put a lot, and we have multiple other awards that I'm not going to share with you today, but workplace culture has really turned in the last few years because of our leadership. We focus on our physicians with GME program and our training because we are a training facility. Geriatrics is one of those things that we do focus on. We have a lot of pediatrics in Tarrant County. Ray talked about that. Geriatrics, we define that as 55 and older. That is one of our focuses. Reduction of infant mortality rate. You cannot be in Tarrant County. You don't have to be a healthcare facility, but that is one of the things that we're focusing on. What can we do in Tarrant County to help reduce infant mortality? We also look at primary care with our patient-centered medical homes. We look at strategic accreditations and designation. The last couple of years we've had level 1 stroke accreditation as well as AMI. And then the ever important destination metric to me is to maintain a positive operating margin. To a lot of you, that may seem like common sense, but that is not always an occurrence, especially in a public facility. So those are kind of our overarching drivers. So where does our money come from? And Ray talked about this a little bit. This is a graph from my budget presentation from 2017. A lot of people are very surprised that we actually have about 40% of our revenues that come from patient services. These are bills that we drop and either Medicare, Medicaid, or insurance companies pay us for. So about another 40% comes from our property tax revenue support. Supplemental funding, the DISH, DSRIP, and UC, which are primarily Medicaid programs. The UC and the DISH comprise about another 17%. And then we have other revenue mixed in there, which is not primarily patient-driven, but could be grants, tobacco fund revenue, could be cafeteria revenue, all other miscellaneous fall within that other portion. Payer mix. I'm going to spend some time on this because y'all had some questions during Ray's slide. And I've got some cheat sheet notes in here. So let's talk about the connection piece of the pie. So if you really want to know what is unfunded for us, it runs about 40%. In my experience, I've worked in 3 facilities for health care. Self-pay runs about 5%. For a normal not-for-profit, it can run anywhere from about 3 to 8%. That's my experience in Texas. Ours runs 40%. So 40% of our patients do not have any type of insurance or funding source. And that's made up of the green, the self-pay, and the connection population. And the difference between those two pieces of the pie is that the connection is kind of pre-screened. And they come in and they apply. They have to live in Tarrant County. They must be a U.S. resident. And they have to qualify under a low-income application. And that's usually about 138% of federal poverty guidelines. And if you want to know what that is, it's about for a family of 3. So a single mom with 2 kids has to make less than around $27,000 a year. So give or take, it depends. You have to go through the application process. But you have to not be eligible for any other insurance product effectively. So if you meet those 3 criteria and you pass the application process for connection, that will qualify you for primary care, prescription benefits, and inpatient coverage at the JPS facilities. Otherwise, the self-pay patient population comes in for emergent care in our facility. The other commercial population could be Aetna, Blue Cross, any other of the commercial contracts that we have that you would probably be familiar with in the marketplace. The ACA plans are also commercial products. We do have a high population of the ACA plans. Those are contracted. You can see that Medicare and the managed Medicare plans make up about another 19%, and Medicaid and Medicaid managed care make up the remainder. So for Medicaid in Texas, that pretty much covers children and pregnant women. Medicare, on the other hand, is pretty much 65 and older. So that is our patient population, and that pie chart shows charges upon dismissal. So that is kind of who we see at JPS. So that was our patient revenue side of things. This is our tax revenue side of things. This is the last 3 years of our tax revenue. We do get about just over $343,000 in this last year's budget for our fiscal year 17. Each year, based on the tax assessed value in Tarrant County, we get a certain percent of the total assessed value of property within Tarrant County. Some of it is new property. Some of it is because the assessed value of the current property increases slightly each year. And this is a slide that I threw in there because I found it really interesting. The CFOs of the big public hospitals across the state kind of got together and put this slide together. It's public information as well. But it shows a 4-year trend, and we're not the highest, we're not the lowest, but we have been consistent at our tax rate, and it's just an interesting slide, I thought. So, and our tax rate has not changed in quite a while. So once you get those components of revenue, how do we spend it? Where does all that money go? You know, people are our biggest asset. They're also our biggest expense in healthcare. So over half of our dollars go into people and benefits. Nursing, accountants, support people, IT, respiratory therapy, all support staff are 52% of the budget. Benefits run anywhere from about 23 to 25%. The professional fees and purchase service, which is the red part of the pie, about half of that actually represents physician coverage. So that's kind of more hands-on. So the people actually kind of extends into about half of that red piece of the pie. The other half of that piece is mainly expenses for our EMR, for the electronic medical record. So again, really focused on the patient. That's the biggest part of what we have to pay for. The supply component are mainly pharmaceuticals and medical supplies for our patients. And then the other operating expense category are kind of miscellaneous things like utilities. We also have minor equipment in there, things that don't quite qualify for capital expenditures that you're going to capitalize and depreciate. You can see depreciation in the purple slice of the pie for major medical equipment that has lives for 3 years. If you're an accountant and understand depreciation expense, we kind of like to buy a MRI and expense that over 3 to 5 years. That's what that depreciation expense represents. We purchase about anywhere from $30 to $40 million of capital every year. And then we depreciate it over a period of somewhere between 3 and 10 years, depending on, there's a whole accountant language of how long we have to depreciate that over. Are there any questions on the slides? Yes, sir.
The pavilion was funded. The pavilion was funded by recurring dollars, and there's got to be some recurring dollars that are being stashed somewhere. Where is that in that pie? In other words, the pavilion was paid for by recurring dollars, not bond dollars or non-recurring dollars.
So these are expenses. So the dollars that the pavilion was paid for were actually cash on the balance sheet. And so this is just the operating budget and how it's spent. So all of this pie represents expenses, and the dollars that would have been spent for capital expenditures are just excess cash that sits on the balance sheet.
Where are you going to show that in a pie chart?
It's on the balance sheet at the very end of the presentation, and I can show you the balance sheet when we get there. So this is a service line for net revenue, and let me spend just a little bit of time on this. I have some experts in the room that have seen very detailed cost accounting systems. I'm an expert on cost accounting systems. We're developing a cost accounting system that we'll be able to generate some reports out of in the next 9 to 12 months. I'm very excited about that. We're not there yet. But what I can do, and what I've attempted to do, is show you based on our collected dollars, just the dollars that we can collect from patients, where does our revenue come from? So from inpatients, I expect to collect $175 million. Now, if a patient came in and we discharged them from an inpatient status, all of their ancillary revenue, all of their drugs are in this side of the pie chart. So over half of our revenue comes from inpatient discharges, half of our collections. Other outpatient, all of the, if you walk in for a CT scan, if you do anything just from another outpatient, that's the orange side, so almost a quarter. If you come in and are discharged on an outpatient basis from the ED, that's about 13%. Psych represents 6%. And if you're on a clinic basis, that's about 10%. So that kind of shows you where, on a functional basis, our collections come from.
Is it psych inpatient only, or is it psych inpatient and outpatient?
That is psych inpatient and outpatient.
It's both. Okay.
Yes. So this is an income statement, which is a lot of numbers, and based on my amount of time allocated, unless you have specific questions, I did not intend to cover this. Unless you have questions on this. And since there was a question on my balance sheet, I will say that our cash is sitting right here. $320 million of cash. And I will say that our March year-to-date cash is highly inflated because our property tax revenue comes in January and February. So remember, we get over $300 million of our support pretty much in the first quarter of the calendar year. And then you will notice that that goes down quickly and, all the way down during the year. And I have a couple of slides on liquidity here that I can show you that. Our days cash on hand over the last 5 years has slowly gone up. Now, I've showed you these at the end of our fiscal year, which is September 30th. So you can see there's a nice progression, or this nice slow uptick. So at the end of 2016, we had 252 days cash on hand. I didn't show you that as of the end of March, once again, because it's really inflated because of that high cash balance, because we just collected our property taxes. So it's not quite apples to apples. And then, as Ray alluded to, you can see in 2014, the net account receivable days was way up, and then it has done a nice taper off, and we're down right at 47 days at the end of 16. Our current bond rating, depending on if you look at Standard & Poor's or Moody, we're at a AA minus or a AA3. Yes, sir.
Sharon, address the significance of that as it relates to the bond rating and where JPS rates to other public hospitals around the country, because I think we're in the top tier of fiscal soundness.
JPS does have a very nice bond rating. There's several factors of our bond rating. Number one, because of our association with Tarrant County overall, there's a very close linkage from the Tarrant County Hospital District and Tarrant County overall. So we almost have a dual rating because of that linkage. And many of our public hospital cohorts have that linkage as well. Because of the way that we have fiscally managed ourselves, and because of the cash reserves that we have maintained, we do enjoy this AA3 rating.
Yeah, and I think this is important because when I first went on the board in 2005, we were highly, highly criticized for the amount of cash on hand. And we tried to resist that. We had to pull some of it down. We did use cash on hand to pay for the patient pavilion. And I'm going to guess that part of that increase in cash on hand that you're showing there for 2016 is in preparation for the next cycle of capital improvements that's going to come out of that cash.
That is such a good segue once again, and we did not talk before.
No, we
this
haven't.
meeting.
In fact,
Yes.
we've never talked.
Yes. So, yeah, so that's a good introduction to my next slide. One of the things that we did to prepare for, whether there is a bond election or not, there is a definite need for facilities at JPS. And so part of what we have done is to repurpose some board designated funds, and we looked at two. There was a depreciation fund and a renovation fund. One was $91.5 million, one was just under $20 million. And we're calling it the JPS Future Fund, just for the purpose of to set aside our commitment to whatever may happen in the next year or two for these facilities that we're talking about. Because if we're fortunate enough to be able to move forward with bond proceeds, regardless of what that dollar value is, it would probably have a component of the bond proceeds, JPS, commitment, and buy down somewhat, as well as a fundraising component. So this is us setting aside a minimum amount of this, as well as, and this amount is not included in the 250 days cash on hand. This is part of our restricted cash. So this is restricted cash, and then we have 250 days cash on hand. So there would be this plus some that we would be able.
Yeah, and then talk about what, comparatively to other public hospitals, what would you say is an appropriate or necessary level of days cash on hand? I mean, because when people hear, are you telling me JPS has $400 million in the bank? Yes.
We also
But what
have
does
a
that
$1
mean?
billion budget.
Yeah.
Yeah. There's a lot of expenses when you look at, we have annually we pay out $500 million worth of salaries and over $1 billion worth of operating expenses. So you do have to put those two things in perspective. We do have a policy that we want to keep at least 150 days cash on hand at any given time. So, and that was set by our...
that was set by the board.
Yeah, it was set. Trent was helpful in trying to establish a minimum threshold so that we did not get into a situation where we were having to access a line of credit for payroll or any kind of a...
But how does JPS compare to other large hospital districts around the country in terms of days cash on hand?
I don't have that information with me today, but I can get that for you and provide it.
Question.
Yes, ma'am.
So for the board designated depreciation fund, one of the questions we had at our previous meeting was about repurposing existing facilities. And a question came up of if there was a list that showed what existing brick and mortar, which structures could be repurposed and utilized for other uses. Is that included in this depreciation fund? And was that information shared with some of the consultants?
I think those are two separate things. The consultants probably have a list of facilities that could be repurposed. This is truly just cash. This is not a list of bricks and mortar at all. This is truly just cash. Yes, ma'am.
So when we talk about upgrading the renovation of existing plant and facilities and investments derived from the strategic plan, that's the bucket, right? So you're just saying that's... Yeah,
these were dollars that had been set aside for that purpose, and we The board repurposed these two funds, and now it's called the JPS Future Fund, just for the purposes of the current building project, the master facility plan.
And I
that we were
apologize,
talking
I
about
don't know all
today.
of this. This
Sure,
is something
no.
that you would know, but for the rest of us that
Oh,
are
no,
just
this
citizens,
is
if you
good
can kind of-
questions.
Can I give us some background on that? I don't know what we're talking about at this point.
So, the master facility plan that the Blue Ribbon Committee is evaluating today, that I just got involved with about 2 years ago. There was the new inpatient tower,
Right.
the potentially new building for the psych inpatient,
Right.
and there were a few other buildings.
Right.
So that's what I'm calling the master facility
thank
plan.
you. Okay.
And we had some dollars that had been set aside on our balance sheet
Okay.
back in '08 for renovation of existing buildings that we just had not spent that on.
Okay.
And when we were going through, Commissioner's Court had asked us, well, what is your commitment to this master facility plan if we happen to move forward with it?
Okay.
And so we went back in and we repurposed these
I see.
funds.
Thank you for the clarity.
Okay,
I wasn't very
you just
clear.
brought up a whole series of questions for
Yeah.
me. So you tell me there's already a master facilities plan with
Exactly.
facility plans involved,
No,
and all
no,
that was
The
programmed
new-
at some point.
no,
And
it's
then-
not programmed. I'm calling the whole thing that we're talking about through the Blue Ribbon Committee and the potential project, the master facility plan.
Okay, let me ask you this question this way. Has there been prior definition of any projections, consultants hired, or any other studies done in the last few years to identify facility needs?
In the last how long?
I don't know, 5 years?
Oh, yeah,
Yes.
Has there?
yeah.
There has?
Yeah.
Okay,
Get your microphone.
okay. Sorry, I'm trying to figure out
What's going on?
if we're rehashing another plan or what's happening.
Well, I don't know if we're rehashing another plan, but y'all are certainly, I believe, using the plans as a basis for further analysis. Both HMA and Cummings has the benefit of our facilities plans that began back in 2010, have evolved with the needs of the district and the needs of the county since then. All of the construction improvements that have happened since 2009 have been done consistent with and certainly not in conflict with those plans that we have developed through the years. And certainly I'll defer to Sharon, but as y'all recall, in our discussions about outpatient clinics, whether it's the new Southeast Medical Home, whether it's the new Northeast Medical Home, those have obviously been paid through funds that the district has had.
Yeah, and there was planning documents, I mean, there's been.
And those planning
the plan,
documents-
the strategic plan, there's been things set in play, there's been consultants hired, I guess.
Absolutely.
Powell was
In
the-
each iteration, or at least any major iteration of those plans are on our website, and I believe linked through the county's website as well. So you can see the proposals from the 2009, 2010 study all the way through today that
Okay.
really perform the basis for our discussions or for y'all's discussions today.
Okay, so some of these got set up at that time, these funds got set up and designated.
This fund
No,
was set up.
these funds-
These funds have been there for.
They've been there a long time.
This is an
Yeah.
accumulation of board-designated funds over the last, say, 15 years
Okay.
Okay.
Yes.
that was
Okay.
then repurposed for this purpose.
Yeah, and the point of this slide is just to reiterate JPS's commitment. And this slide was actually pulled in from my budget presentation to Commissioner's Court back in September. Just to say, we have set aside $110 million to, if we're lucky enough to move forward with a bond issue, there's $110 million sitting on my balance sheet currently. And we have additional funds that would likely be added to that.
Okay.
So,
Okay.
and if we do not move forward, we still have $110 million
Okay.
set aside for construction of some sort.
Sharon,
JPS
is
has-
this an amount that back in 2006 or 07 or 2010, I guess what you said, is this something that gets added to each year, but does the commissioner,
It
do they
has-
vote on, let's add another 10 or?
No, it's not anything that the commissioners had done. It is something that had happened prior to my arrival at JPS. It was done, actually, it's a board designated fund. So our board of managers actually had set this aside at some point.
And do they do that every year and say, okay,
No.
we want to allocate 5 this year? No.
No.
Just-
It's actually building up in our days cash on hand.
Yeah.
So, yes.
Well, actually, JPS has committed to adding more cash to the JPS Future Fund
Yes,
to help with
Right.
the future. So
Out of the day's cash on hand.
right, on an annual basis. So
On an annual basis, you put some over there.
yes.
So maybe this fiscal year, there may be X amount of money add to the JPS Future Fund.
Yes.
Because it's so over their projected target, I mean,
Right.
It's an accumulation of cash
yeah.
to plan for future renovation and expansion. Looking at the facility, we expect something have to be done,
Yeah.
okay?
Mm-hmm.
So, right, if you are planning
It
to improve on the existing facility, it would be wise to begin the accumulation of cash. And the board of managers had had the foresight to plan for these. So right now, at least we have $110 million to start with. This year, the board may decided to add a few more millions to it next year and so forth.
Right. Yes, sir.
But the average taxpayer doesn't know about this.
Agree.
The average taxpayer has been paying in, and these are looked at from taxpayer's standpoint as recurring funds. Now, if you build a building with that, and you build that building one time, it's a non-recurring cost. So really it was thrown into a pot as recurring funds, and it's going to be turned into non-recurring funds if you decide to build some capital equipment or monuments. And so the average taxpayer has no idea that there's already $110 million in the pot for building facilities and whatever.
But each year, just to be clear, we spend $40 million on capital. So,
I guess I'm not clear on your phrase, not recurring
It's coming out of
funds. I mean,
these.
no, these are
Recurring
set
funds is
aside.
funds that you spend every day for salaries and this.
well, yeah, that, yeah.
The
okay.
non-recurring fund is a building a monument, like a building or a piece of equipment that's going to be there for 20 or 30 years.
So it's like operating expenses versus capital expenses.
So I also included the hospital's cash flow just to let you see how those days cash on hand had built up over the year. We did have a net income of $26 million and this is for fiscal year 16. Depreciation gets added back to that and changes in working capital. The supplemental funding, the state, those next 4 lines, the state did catch up on a lot of its activity on supplemental funding. It's very complicated. But, and then again, we did purchase a lot of the capital equipment and construction. So we did net out about $84 million last year.
Which is a significant increase if you compare that to the previous 5 years.
Yes,
Right.
we
'Cause, I mean,
do
there were years
continue
that
to
we
go
were-
up.
Yeah, there were years that we were budgeting a net loss.
But
in the
quite
5
a
to
bit
10
of
million
that,
range.
as Ray had alluded to, is a lot of the timing of those,
Right, exactly.
the state payments on settlement of the waiver funds. And that was my prepared comments, unless you guys have any more questions. Thank you.
I had a quick question.
Yes, sir.
It was about slide 6, but you showed the tax revenues from the county.
Yeah.
Do you have any way of allocating where those funds come through relative to the patients you serve? Like, are 80% of the funds coming from Fort Worth property taxes, or 20% from Arlington, and how many patients come from those jurisdictions?
We don't do an allocation. Those just go into the top side of our income statement. We don't try to
But I
match
think
up.
it'd be searchable, because you know where the tax revenues come from.
Yeah.
You know where the patients come from, but you could figure that out, couldn't you?
That information is actually available from a appraisal district by municipality.
But then you have to correlate it to the patients that are served in the hospital system, in the GPS hospital system.
We have not done that in the past, but so many of our patients come from outside the
Well, that's what drove the
county.
question, because we're
Exactly.
serving so many other jurisdictions that aren't in the tax base, and they're also, well, I think a lot of the tax base is probably relative to the patients being served, paying more in than, so I'm just trying to figure that out.
Yeah.
So those that come from outside of Tarrant County, do you have the cost breakdown of those patients? How many of them actually pay? How many of them?
We
insurance?
have which ones might be self-pay. I don't have the costing out of those patients without a robust cost accounting system like I mentioned earlier. We're still developing that. I do have the payer class of those, whether they're self-pay or they're insured, the ones outside of Tarrant County.
And most of those outside of Tarrant County are emergency room related, trauma related.
Right, trauma related.
And we do get money from the state trauma fund, not a huge amount, but the state does reimburse us with a special trauma fund. What's the number?
So do you have a
I don't remember
way
what the number was, but
do you have a way to give us insight to the net gain or net loss for serving those patients outside of Tarrant County?
Again, I can separate, I cannot drill down into a net loss or net gain number because I can't go in and separate. You think about trying to separate salary costs from the inpatient population. That's a very complex math procedure to go through without a true cost accounting system. And again, we've purchased our software and we're in development of that. And the reporting won't be ready probably for another 9 to 12 months. But so I have to say I'm not able to do that currently.
Understandably, yes.
Yes.
Thank you.
But Commissioner, you have to have that kind of information if we're thinking, as Ray had suggested, going to the governor, to the legislature, to see if we can get more reimbursements. You know, this thought about
Right.
for all these other
Exactly.
folks. We have to have that kind of data to support that.
Right.
Because you got to know the impact and the financial cost.
That cost accounting system, when she gets it in, she'll be able to do it then.
Yeah.
So, I mean, that's surprising, just out doing that. I'm glad you are, because.
But I think even with that number, and you know, other healthcare folks might be able to shed some light as well. Even if you have the number, it's going to be a very difficult process to try to gain more dollars from external sources, even if you have the dollar of losses that might be coming in from outside Tarrant County. It'll be great information to have. I don't know if you'll be able to legislatively bring in more cash to our facility.
and getting an external county to vote to send money to Tarrant County, it ain't gonna happen.
Well, but they're,
Just like Andy ain't gonna vote to send money to another county.
Highly unlikely.
Highly unlikely.
It's all really interesting information to have, but to actually secure extra funding, it would be unlikely that information would provide
And get more
that
money out of the
opportunity.
legislature, I can assure you,
Yeah, and then-
highly unlikely as well.
That'll be a collated.
Well, maybe the increase of the fund you mentioned would work, a way to get that.
Well, I can't remember what
changes in that.
Yeah, I don't remember what the source of that trauma funding is.
So most of our state funding, I will mention to you, most of our state funding that we get to report to does include a self-pay component, which includes the it's regardless of whether they're Tarrant County or non-Tarrant County. So when we report to the supplemental funding to the state, it includes all self-pay. It's not just Tarrant County. So the supplemental funding component that we do get includes all self-pay. It's not Tarrant County versus non-Tarrant County. So those components are covered from a state standpoint.
Just isn't a very big number.
It's just, it's, yes, the state doesn't care which county they live in. They are reimbursed to us at the same rate.
Okay.
Yes, so there's no differential of what county they come from a state standpoint.
Gotcha.
Yeah, so we're covered there. Any other questions?
Thank you very much.
All right.
Appreciate it. Yeah.
Thank you, Sharon.
It was a pleasure.
Very interesting. All right. Well, Ms. Co-Chair, our first long meeting.
Yeah,
We did pretty good, though.
yeah, we did.
Quarter after.
It's for
Ken,
the corner.
at our next meeting, we're gonna go back, we're gonna do the 130 again, because I think it really helps us. If you read through all of the information, even scan through, it's a lot of stuff to try to internalize and understand. So when they make the presentation, so we're gonna do this again at our next meeting, start at 1:30, so we can plow through this and move this ball down the field. Is that okay? Mr. Co-Chair?
Yes, ma'am.
And we will have sandwiches again.
All right.
All right.
Good.
And JPS.
And what?
The cookies. And the
JPS cookies.
Make sure those
Okay.
cookies are here.
They're made out of tofu.
Well,
Seriously,
I think we've done a good piece of work today.
yes, ma'am, the meetings, the videos, the documents, all the presentations are available to the public at TarrantCounty.com/en/JPS. So an average taxpayer does have the ability to gain the information. The question is, will they?
Yeah.
So that's the best we can do.
You know, the other thing that struck me when Sharon was mentioning the award today, how many people, besides us sitting in the room, how many people really know?
Well, hopefully it's gonna be on,
It'll be a press release.
hopefully it'll be on the front page of the Star Telegram.
They found out last night.
Yeah.
How many people read the Star Telegram?
But
I'm not gonna go there.
But I think this falls into what we're trying to do here, to raise the public awareness of what's going on, and if we don't toot our own horn, who will? And so I hope that John Peter Smith will make a concerted effort to make sure the public. Okay, good.
So if you strike a deal with Ron Wright and include that press release in your tax statement,
Strike a deal with Ron. Anything else that we adjourn, sir?
No, ma'am, I think we're adjourned.
I want to mention one thing, that linkage that Commissioner Wynn talked about also has linkages to the JPS work that they've done prior to this committee too. So there's a lot of history out there. So.
Thank you.
Okay.
Thank you.
So, we'll be good if you